know the guidelines that are prevalent in NHS on which questions are frequently set, and do some questions. So, as we all know, it's oral to aboral. So, starting with the oral cavity, as you can see, this is a white patch which does not peel off, and it is a pre-malignant lesion. We call it leukoplakia. The same white patch, which is a bit shaggy, which typically occurs on the sides of the tongue and associated with EBV, found in HIV positive patient, called oral hairy leukoplakia. This is a typical aphthous ulcer, where there is a central ulcer surrounded by halo of redness, which occurs on non-keratinized mucosa, heals without scarring, and may be idiopathic or associated with Crohn's disease, celiac disease, Behçet's disease, trauma, erythema multiforme, lichen planus, infection. Of this, Behçet's disease is very important. Treatment includes hygiene, avoiding trauma from sharp cuspal edges of teeth, chlorhexidine mouthwash, topical corticosteroids, and oral thalidomide for recurrent aphthous ulcers. If the ulcer persists for more than 3 weeks, we have to go ahead with biopsy. Angular stomatitis is very commonly seen with riboflavin deficiency and iron deficiency. Gingivitis, that is, you can see tartar in between teeth. You can see eroded buccal mucosa, the gums, which occurs with poor hygiene, can occur with pregnancy, vitamin C deficiency, acute myelogenous leukemia, and Vincent's angina, which is caused by Borrelia vincenti in male smokers, which is treated with oral amoxicillin or metronidazole. Gingival hyperplasia, as you can see, the gum usually is in between teeth and ends at the upper border of the teeth. Now, if the gum encroaches in between two teeth, we call it gingival hyperplasia, and it occurs typically with calcium channel blockers, cyclosporine, phenytoin, and a host of other drugs. This you can see there is narrowing of the oral aperture, there are radial furrowings, and there is pinched up nose. So this is a typical systemic sclerosis which causes microstomia. Oral pigmentation. This is a very important part which is frequently given as case in MRCP questions, which is a Peus-Jeghers polyp. It is an autosomal dominant condition associated with LKB1 STK2 mutations, which is characterized by numerous polyps in GIT, freckles on face, lips, palms, soles, can cause intestinal obstruction, intersusception, gastrointestinal bleed, cancer, and the risk of cancer is 50% by the age of 60 years. So questions based on GI bleed with a picture showing freckles on the lips or face or palms or soles, the answer will be Peus-Jeghers syndrome. And Osler-Weber-Rendu disease is characterized by telangiectasias and pulmonary AV malformation. So, Osler-Weber-Rendu disease, they present with various forms which we will discuss when we come to them accordingly. But the basic difference is because people do sometimes mix them up. So, Peus-Jeghers polyp, you get freckles, and Osler-Weber-Rendu disease, you get telangiectasias or dilated capillaries. Macroglossia, as you can see, the tongue is large. When you call it as microglossia, when there are impressions of teeth on the sides of the tongue. So it is characteristically found in myxedema, acromegaly, and amyloidosis. So questions can be set on various aspects. For that, you have to know each disease in details so that you can answer them accordingly. Now, investigations. The common investigations which are done in gastroenterology includes other than endoscopy, colonoscopy, routine blood. We will not discuss about endoscopy or colonoscopy or routine blood because they are known to you. Routine blood we will discuss on LFT patterns when we come to hepatology. So here we discuss about enterography versus enteroclysis. So MR or CT enterography or enteroclysis is done to evaluate the small bowel. When you get a patient of GI bleed, you have done an endoscopy, you have done a colonoscopy and both revealed nothing. Then you can go ahead with MR or CT enterography or clysis. So enterography is a non-invasive technique. The contrast is used orally. As it is non-invasive, patient tolerates it better. It is a conventional type and accuracy is low. But enteroclysis is invasive. You have to put in an nasoduodenal or nasojejunal tube, as a result of which acceptability is poor, and it can be conventional, CT or MR based, and it is a better modality. Coming to X-ray. So you can see there are hypodense lesions all over the hepatic parenchyma. So these are portal venous gas. So what is portal venous gas? Portal venous gas are peripheral gas and they are typically found in mesenteric ischemia. And if someone finds portal venous gas on CT, that means you have to act very fast. And this you can see, it is not scattered throughout the hepatic parenchyma. It is more or less concentrated around the gallbladder, common bile duct, intrahepatic biliary radicals, and we call them pneumobilia. Pneumobilia is a benign finding which is found post-ERCP, stent or sphincterotomy. So, Rigler's triad, which is characterized by a gallstone slipping into the gut, resulting in small bowel obstruction, pneumobilia, which is the gas around gallbladder, CBD or IHBR, and you can find a gallstone in the right iliac fossa. So this you can see a typical coffee bean sign which is found in sigmoid volvulus, and the usual characteristic scenario is an elderly psychiatric female with absolute constipation or obstipation, hostrations are absent and there is massive distension. Coming to bowel obstruction, how do you differentiate between small bowel and large bowel obstruction? So diameter in case of small bowel would be more than 3 centimeter but less than 5 centimeter. Location will be central. There will be multiple air fluid levels. You will find valvulae conniventis and gas in large bowel will be absent. Large bowel obstruction diameter will be more than 5 centimeter, more than 9 centimeter for cecum. Location will be peripheral. There will be few massively dilated air fluid levels. There will be hostrations and gas in large bowel, it will be dilated. So this is a typical small bowel obstruction where you can see valvulae conniventis and you can see the location is central. On the contrary, large bowel obstruction, you can see hostrations and massively dilated large gut with a cutoff at the site of obstruction and characterized by hostrations. Coming to hepatobiliary and pancreatic imaging. So as I have discussed, pneumobilia is air in common bile duct, which is central. Portal vein gas is scattered in liver, which is peripheral. Calcification you get in recurrent pyogenic cholangitis. Remember this, recurrent pyogenic cholangitis. And ERCP you do for stent placement and obstructive jaundice. Coming to a very common modality, which is the triple phase contrast enhanced CT or multiphasic contrast enhanced CT. So you push in dye into the patient and you take sections in 3 different phases. One is the arterial phase, followed by the portal venous phase, followed by the hepatic venous phase. And they help you differentiating the lesions. So what is arterial phase? When you can also see contrast in aorta and hepatic artery. So during arterial phase, normal liver does not enhance. It occurs within 30 seconds of contrast administration. And it is typically informative about hepatocellular cancer, hemangiomas, hypervascular metastasis, which are typically found with thyroid, RCC, choriocarcinoma, neuroendocrine tumors, pheo, and melanoma. On the other hand, portal venous phase, now the liver gets enhanced and it usually occurs 60 seconds after contrast administration. And it is very useful to diagnose liver metastasis, which are hypervascular or portal vein thrombosis. And the last is the hepatic venous phase, which occurs 3 to 5 minutes after contrast administration. It is used to diagnose Budd-Chiari syndrome or kidney ureter bladder abnormality. Now, so there are three phases: arterial phase, portal venous phase, hepatic venous phase. So what is the importance? You get a lot of diseases on CT. You can get a hemangioma, you can get a focal nodular hyperplasia, you can get a hepatic adenoma, you can get fibrolamellar hepatocellular cancer, you can get hepatocellular cancer, you can get serous cyst adenoma of pancreas, you can get mucinous cyst adenoma of pancreas. Coming to hemangioma. So hemangioma, in the arterial phase, there will be a nodular enhancement of lesion, which is peripheral. Central part will be hypodense. And during portal venous phase, there will be centripetal filling, and during hepatic venous phase also there will be centripetal filling. On the other hand, hepatocellular cancer, there will be brilliant arterial enhancement and rapid venous washout during portal venous and hepatic venous phase. So this point helps you to differentiate between HCC and hemangioma. Nowadays, if you get a liver SOL and you get a characteristic arterial phase enhancement and venous washout on CT scan, you do not need to do a biopsy to diagnose hepatocellular cancer. Coming to focal nodular hyperplasia, it is usually benign. How will you diagnose it? There will be a central scar which will not enhance on arterial phase and they will enhance on delayed phase. Hepatic adenoma. They are frequently found in patients who use oral contraceptive pills, but they will enhance during arterial phase, and during portal venous phase there will be isodense, not hypodense like in HCC. Fibrolamellar hepatocellular cancer occurs in young females, normal alpha fetoprotein levels. There will be a central scar like FNH, but there will be stellate calcification. So to summarize, arterial enhancement will be seen in HCC and FNH. HCC and hepatic adenoma. In HCC, there will be hypodense on portal venous phase, whereas in hepatic adenoma, there will be isodense on portal venous phase. And the lesions which do not enhance on arterial phase but enhance on delayed phase include FNH and hemangioma. Hemangioma though fills up, but FNH will not fill up. So again, I am reclassifying arterial phase enhancement, HCC or hepatic adenoma. Portal venous phase hypodense, HCC, isodense, hepatic adenoma. OCPUs, hepatic adenoma. Normal alpha fetoprotein, hepatic adenoma. Peripheral enhancement during arterial phase, centripetal filling during delayed phase, FNH with a central scar. Central scar plus stellate calcification, fibrolamellar, HCC. Serous cyst adenoma of pancreas usually occurs in the head of the pancreas, which usually occurs in 6th decade, so-called grandmother lesion, whereas mucinous cyst adenoma of pancreas occurs in 4th to 5th decade in the body and tail, and they are usually called mother lesion. And mucinous cyst adenoma of pancreas is a pre-malignant lesion. So this is HCC. The next one is hemangioma. This one is hepatic adenoma. You can see a stellate scar, central scar. And this you can see a FNH. This is a cyst adenoma of pancreas. And this is a hepatic hydrated cyst. As you can see, many dotted cysts. Any questions till now or any misunderstanding till now?
Can you repeat the pancreatic cystadenoma, the findings of CT?
Serous cystadenoma pancreas is a benign lesion which occurs in the body of the pancreas.